Yeah, thank you for the kind introduction, and it's a pleasure to speak as part of the seminar series. So Kate and I are very excited to be asked and to contribute to the seminar series, and we hope not to be too wicked today with you. And unfortunately, I think we're so used to doing these things now on Zoom. While we would have probably preferred to have you all in one room and probably work more directly with you and in a more interactive way. So this seminar today might be slightly different to maybe some of the previous presentations that you've seen as part of the seminar series. We're not going to produce or present many particular results. We won't present any statistics. We won't present any particular research findings from surveys or from intervention studies. What we're going to do today is to look briefly at the notion of wicked problems, and then we'll talk a little bit about sort of how are we generating actual research at the moment, and how do we find potentially alternatives that can address some of these challenging problems, particularly in the area of health, housing, and rights-based approaches. So that's just as a brief introduction here. So I'm just gonna go through the slides. So as an overall aim for this presentation of the seminar today is, first of all, to characterize complex problems and challenges, and why we need individuals and communities to actually generate answers. Then we go into the notion of collaborative engagement, co-designing solutions, which is again nested sort of in a more broader approach of working with the public, working with stakeholders. And then we provide some examples from our work that we've engaged in with our partners, various partners in Ireland, but also beyond Ireland. And then we draw it all to a close. I hope that sounds interesting enough. And without further ado, I'll jump right in here. So wicked challenges for public and community health, and all of you will be aware of the complexities involved in the social dimensions of the social determinants of health that often link together health outcomes to living circumstances, relationships, housing scenarios, behavioral lifestyle challenges, and so on. So they're all interlinked in the complexity that is very difficult to reflect in research at times, because you only have resources or you only have opportunities to put the zoom lens on a number of variables. But nevertheless, we know they're operating in these very contextual and multifaceted ways. So how are wicked problems defined? So the term has been around in the literature for quite some time, but it's really sort of the notion of describing some of the most challenging, complex issues, these intractable issues of our time that threaten human health and well-being. And here listed some examples: biodiversity loss, persisting poverty, advancing obesity, epidemic, food insecurity, all those things. And I think over the last couple of years, I think we've been reminded of some very current additional challenges linked to the corona pandemic and the current war in Ukraine, and how it affects globally some of these challenges like food security, supply issues, the economy, and the general well-being of the population. So around the globe. Here's just an illustration of how some of these complexities can be visualized, and this is taken from an example for an individual causal loop diagram, which is a way to illustrate or visualize these challenges and complexities. And if you put your attention to the center of the slide, the quality of family life, and you see all these variables around there that can have either a positive impact on quality of family life or a negative impact, and how they are interlinked. So this process is a very dynamic impact on the quality of family life. If we take for instance the notion up there about health status, addictions obviously have a negative impact on health status that might affect job security. Addictions have a negative impact on amount of finance, and so on. Amount of finance, if that goes down, has negative impact of life certainty, and so on. So there's that complex systemic interconnection between these different elements. So today we want to focus the research more on research that's being conducted with stakeholders and doing things together for changing things, rather than doing research about or developing interventions for people. So this is a cultural shift, and that has a tradition that has in the social sciences taken root, many decades ago. But it's currently just finding its way probably more into the health and social care arena, in terms of how we shift actually to this collaborative approach of finding solutions to these very complex and wicked problems. And some of the reasons behind that is in working collaboratively and working with stakeholders closely, is to understand the values that individuals, we use here a lot the terminology of patients, but it could be replaced with individuals or persons or families, depending on the circumstances. So working right from the start, of research and processes to identify solutions to wicked problems, we understand where people are coming from, the values, the preferences, priorities. We can learn about their complex living circumstances, just like you saw on the slide just before, how they're all interacting in very complex and dynamic ways. We also can understand better the disparities in terms of accessing perhaps and using services, public health, general healthcare services, social care services. And we engage in shared decisions with them rather than presenting them with professionally and academically defined decisions. Working collaboratively can also inform the coordination and continuity of care, identify some of these gaps for integrated and continued services, especially in defining pathways of services and care. And working together can also challenge and ought to challenge in some ways, the reductionist biomedical understandings of health and well-being, because we need to have that awareness of the ecological systems in which people operate and live and act. Finally, I think working collaboratively can inform us in terms of how we should collect data, and also collect the right data that is meaningful, purposeful. So we can easily miss, the meaningful data if we don't work with stakeholders at the outset. So in terms of health systems, Lazarus in France in 2014 put out a paper and said basically working with patients, working with people at the heart can really be crucial in order to how we think of our healthcare system, the building blocks that are attached to that in terms of service delivery, health workforce, health information systems, the access issues, the financing, leadership. So if we bring patients into the research processes around health systems research, but also in terms of health systems design, we you can really learn what matters to stakeholders, which groups are being left out, which groups are included, what needs to be done in order to be as accessible, inclusive in terms of these areas on the left in terms of the communication processes. And then this will ultimately translate into better health outcomes, a more responsive system, and ultimately, also improve its efficiency. So building the patient voice right there at the heart and center of it. Oops, sorry. So public engagement, or in the healthcare arena, we often speak about public and patient involvement. And there's a plethora of terms that in many ways overlap, but also sometimes differ. We're not going into that minefield today, but funders increasingly from the European Union funding, from the Horizon program to SFI, to the Irish Research Council and the Health Research Board, they mandate sort of a plan, for involving members of the public or patients in the design and the implementation of the research, and also in characterizing how PPI or public engagement will affect the pathway to impact and to make that research investment useful. So this is just a slide to show that actually this is of high currency at the moment, because there's hardly a grant application that can be completed without prior engagement or working with members of the public, patients, or citizens. So the National Institute for Health Research is the one that has initially sort of kick-started, at least more visibly, I think, in the Anglo-European world, the Irish world as well. So in terms of how we define public involvement, and it's related to what I had up there on the slide earlier, sort of in terms of doing things with and by members rather than to or for them. And there's a fairly wide definition of what constitutes patient and public involvement. So that could be patients and members of the public themselves, their partners, their carers. So anybody who uses services, health and social care services, or people from advocacy organizations as well. So the drivers of PPI, public and patient involvement, are manifold. As was said in the introduction, and we've said in our abstract, there's legislation, and the human rights legislation around, for instance, the United Nations Convention on the Rights of Persons with Disabilities, but many other legal instruments that mandate actually that stakeholders have a say in decisions about their lives. And that includes actually how data are being collected, how research is being conducted, and so on. So it's a legal requirement and legal mandate actually for us to involve stakeholders. There's in the healthcare systems worldwide, and that's not a new thing to all of you, probably, is the economic pressures, in terms of reducing healthcare costs, and in lean or in quality improvement speak, you would say, cutting out the waste, and so you want to have solutions for some of these wicked problems that are as cost efficient as possible. And that means to generate a better in-depth understanding of the perspectives and experience, expectations, and values of citizens. We also see technology and driving having a major role in driving citizen empowerment, and as people, consumers or customers or members of the public in general, demand to have a say, demand to be involved. And social media and the way we use technology nowadays has accelerated that process. And then finally, so the academic side of things and the funders environment, obviously has shifted to greater awareness, that actually PPI can deliver benefits. So as was said in the introduction, so I'm currently the lead for the HRV-funded public and patient involvement initiative here at UCD. So, but the national network, the PPI Ignite network, is led out of Galway, NUIG Galway. And this is a very complex slide, and I don't want you to dig too deeply into this. This is a massive operation. It involves sort of 7 universities as core partners across Ireland. In addition, we have Maynooth University as a national partner as well, and Queen's University in the north of Ireland. Then we have various national partners, the Trials Network. We have IPOSI, an industry patient platform. We have the Health Research Charities Ireland, the HSE, TUSLA, and Campus Engage, the IUA. So they're all involved in this national network initiative. So, and with that, Ireland has taken a very unique approach actually to really bring that engaged working in the area of health and social care research to a national level, and really trying to drive this cultural change. So this is co-funded from the Health Research Board and the IRC. And on a different occasion, we can perhaps talk more about some of the details that this national network does at the moment. So this is a slide that we've been using here at UCD. It's an adaptation of the Wellcome Trust onion. We call it the avocado here at UCD. And this was very much collaboratively developed with actually staff, students, and the public of how we see engaged research, engaged working. And what we want to focus on a little bit more today is that co-producing, that co-designing element, which you see here indicated with the orange arrow, which is the nucleus of engaged working. The outer layers are more disseminating to and tailoring sort of communication messages to individuals and organizations and communities. And the further inward you go to the avocado, the more collaborative the work is happening, and that's what we want to talk about today. So, in terms of design and empirical research, design thinking and empirical research, and Kate will speak in a moment about design thinking, but I just thought it would be helpful to just look at maybe these two complementary approaches that we are talking about today. So science, obviously is about generating an evidence base in terms of a structured and systematic research process, and has a past-present orientation. So we are accumulating an evidence base, we're synthesizing the evidence that's there, identify the gaps, and it's basically focused on what do we already know, and the scientific inquiry is very much about minimizing error, minimizing bias. So design or design thinking is very much focused on where we are now, and is looking towards the future in terms of identifying potentially solutions, but also allowing us to potentially fail on this process. It's a process that's not only driven by rational synthesis of evidence, of data that we have, but it's drawing very much on softer, what's often called or termed as softer elements in terms of experiences, intuition, human playfulness, and the willingness to experiment, to try things out. And it's very much looking at the human as a creative repository that's often untapped, and we can tap into that in terms of identifying new and different ways that could potentially solve some of these complexities that we talked about, but without sort of the ambition to get it right in the first round. So I think with that, I just stop and hand over to Kate. We'll just have a little bit of a switch over in terms of the slides, and Kate will continue where I stop, and then I come back later.
Thanks very much, Thilo. I'll just screen share here. Okay, everybody see that? Yep. And thank you very much, Thilo. And I suppose really just following on from where Thilo has brought us to in this presentation, it's really what I'm going to focus on more is this co-design and examples from work and projects that we have engaged with. And in particular, I'm going to talk about 2 projects. And I suppose the narrative around my interest in this area both comes from my experience as a professional, as a nurse, both as an academic, and also my own personal experiences both have kind of brought an additional lens, both from my experiences as a patient, as a parent, and as a carer. And I suppose it's all of that that actually leads me to the shaping of the research that I engage with at the minute. So I suppose when we think about co-design, we really think about the what. And why is it important to kind of think about this, and why are we actually interested in it? And in a recent rapid review by Slattery, they identified a number of studies, up to about 26 studies, that noticed this varied adoption of co-design. And the rationale for co-design is that it can build important links with the community and help with assessing participants, improve response rates, and really help to hear from those seldom heard groups. And I suppose that's often the focus of particular populations that we're interested in. And this development of greater empathy, really focusing on the problem from the perspective of the person and the people involved themselves. And public and patient involvement in particular can help in the assessment and development of research instruments and can improve the timing of intervention. So really, the person who has that particular issue and the population that we are drawing from and engaging with, but as equal partners, they have such expertise to bring to research projects that needs to be harnessed and enhanced for ourselves. And the rationale of why we need to do this, I suppose, has been, we've read about this from so many different papers and, very many different sources around the amount of money that is invested through, the waste of sort of like health research that fails to create meaningful benefits for people, and kind of look at, why does that happen? And really thinking about sort of like engaging in co-design. Why is that so important? Because maybe actually working with people, as often has happened in other industries, and maybe not necessarily in health to a greater degree, can actually help address actually what's useful for people, what could work in practice, and where do we need to get that information to help fix and work with people to actually find potential solutions. And even to acknowledge that there may not be one particular solution, but actually it's a more agile process in how we engage. And when we think about design thinking, when we think about what types of processes and approaches can exist, what's involved in doing that, and how effective are they? And I suppose one of the issues that Slattery brought up is really to kind of think about, when is it worth to engage with people, and what are the ideal activities to use in specific contexts? So it's that idea of, the when and the what. And the why really that we think about then is where they have said that the ultimate aim of health research is to provide that evidence for insights to improve health. And what they have said, and I say, Doug Altman for many years has really reported on, do we need more research? Because really the staggering waste is in excess of 170 billion. And that is through sort of like what people are reporting through their non-reporting, through incomplete reporting, or through poor design. And then that doesn't get published. So there is an opportunity of the why we need to do something differently. And I suppose, Glazier and Chalmers, they gave the analogy that really, if health research was a transport business, we would be appalled by this data. Half of the goods carried would be badly designed, half lost in shipping, and half the remainder broken by the time that they arrived. And they say it's a truly heartbreaking waste. And often kind of thinking about that, why do these things happen? So are there other ways to approach how we engage with people and the research that we do? So as I say, one of the areas that we engage with is design thinking. And that very much starts with putting human-centered design to ask how new approaches and really put the problem at the center. That really starts with the people, involves observation, conversations with them, and collaboration, and very much on an equal footing. It is both collaborative and inclusive. And what we very much are aware of are the community are experts in their own lives and creators of their knowledge. They're not passive subjects. And really that can feed into that broader perspective of the social determinants of health, to really engage with the communities that we are less familiar in actually engaging with and why they do not engage, and learning more from them by actually going out and talking with them and bringing them on board as equals where that is possible, and finding ways to identify how we can do things differently and really adopt this creative mindset and move away from the institutional and the linear thinking. And one of the approaches for design thinking that we have been very much involved with, or we use, is called the Stanford D School Design Thinking Process. And it has 5 different approaches. And the approaches that they take are very much empathize that very much. And empathy is crucial to human design-centered processes because it very much, it works with people, it meets people where they're at. And it is non-judgmental, and we're seeking to understand and work with people because they are the experts in that particular area. The second part of the process is to define, and that's where working with the information that you have gathered through the emphasize phase, there you can look to analyze your observations, kind of work out what the core problems are, and work as a group then to come up with what we say as a problem statement that is very much human-centered at its heart. Ideate is the third process that they talk about, and that is very much where we consider types of solutions that may be, how might we solve this? But it's not done through black and white binary thinking. It's done through very much broad sharing examples and very open. And there's processes involved in that so that it's not the loudest voice carries what the solutions would potentially be. And then the prototype takes us to those types of solutions. And as we said, it's an agile process. So we can use different methods to actually capture that information through storyboarding or through different ways to actually, as we will show some examples of what we have used to actually undertake this. And it's very much fast. And part of that then, when we get to those prototypes, is to, through that agile process, is then be able to test them in practice with people, with the users, to kind of see what works, excuse me, what needs to be adapted and what needs to be changed, and to kind of see how successful it is. But it's iterative. So we can go back and try these again. So that is kind of like at the heart of what we do in relation to the design thinking process. And some of the examples then, I suppose to put it in context for what we do, is one of the projects that I was involved in, excuse me, is to do with smoke-free homes. And it was a funded study from the Irish Research Council and the Economic and Social Research Council. And it was to develop up a 5-country network to look at how we broaden our knowledge and understanding of why people in Ireland and the UK continue to smoke at home. And the objectives were very simple: to build relationships between broad academics, third sector groups, policymakers, partners as well, to share expertise, and to engage with parents and carers, again, through PPI and through co-design, to ensure that their needs are presented. And that would then enhance further grant applications as we move forward. So there was nothing startling about that. But what it really was to say was, why did we need to do this? Because when we look at the evidence in relation to smoking cessation and why people should not be exposed to secondhand smoke, there is so much evidence that is produced out there. So this is the evidence that has been produced. It is available to people. And yet, if we look in Ireland, we know that currently about 17% of the population overall smoke. And for those who are in lower socioeconomic groups, that can rise to round about maybe 23, 25% and up towards of maybe 40%. So with all this evidence and all that we do, what more do we need to do to be able to support people and to actually help them to reduce the impact of smoke exposure for children in particular in the home? Because under, as we say, the human rights and the UN Convention on the Rights of the Child, you know, everybody has the right to health, but children in the homes where they are very much impacted by what is going on around them and the environment that they're growing up in. So they may not have choices. So whilst we can have all the WHO frameworks and all the guidelines and legislation, policy, pricing and advertising, we still have much more to do. And that's to actually speak to the people who are still smoking and those who have been successful in quitting and find out ways that we can actually make a difference there. So it's to change the lens. And part of the network that we brought together, it was transdisciplinary. So it brought together both, you know, colleagues from medicine, from psychology, sociology, you know, from economic background, from education, public health, social justice, and also through policy as well. And what we have found is to actually put a different lens on that and really focus in on who are the people that we least hear from, the parents, the single parents, fathers, and views from children themselves, and actually be able to make a difference there, because all the literature points to we need to give every child the best start in life. But how are we managing this and how are we doing that? And can design thinking processes give us an opportunity to learn a little bit more? And the reason that we wanted to do this is that flexibility, to be able to tailor involvement to the topic and to the research question, rather than just come at it with what we know already. So we need to do something that is more agile. And what we have found is, and Thompson has said, that people often succumb to their own ways of approaching an issue within their own disciplines and areas of expertise. So in a way, we are stepping outside of our own comfort zone and actually approaching it with a level of uncertainty and kind of being curious to kind of see what more can we learn through actually listening and engaging with others and allowing all viewpoints to have a way to be heard. And this then would speak through, as we said before, through Ornstein's ladder of engagement, and as Thilo has identified through the work of PPI. And you can see that very much sort of like the work that has been done before in research where we would have engaged with, it is often through that engaging and talking to people. But where we were up to try and do was to co-design and to co-produce outcomes and prototypes to actually with people and have them a centre. So through what we did was a number of workshops that we held, both with practitioners in Ireland. I engaged with members of the public, people who smoked, people who had quit. We ran a co-design workshop. We also held workshops with members of the network who then comprised the broad transdisciplinary groups. And it was interesting to kind of see where the different perspectives arose through our different methods of information and data capture. And in speaking with and in linking with our workshop with practitioners, what we identified was who's invisible to their particular services and who is visible but doesn't engage with services. So that highlighted where we have particular approaches, but they're not tailored to those groups who don't engage. And what emerged from them can often be around the seldom heard voices groups, and that could be through challenges around literacy, through fear of authority, through actually having no agency in their lives and other particular issues of what they prioritize as well. And people who may not be in a system, people who are not connected into systems, and then may not actually be able to engage with what we think is very simple ways of why don't they pick up the phone? Why don't people approach others? And why don't they do it? That's often the questions asked. Why don't they? And that language and changing how we engage with, well, what do we need to do to be able to come alongside people? From the professional and the academic and the policymakers' perspectives, what we identified from them was the different perspectives we have within the 5 countries, and even within an all-Ireland basis of how different policies are actually being generated For example, the banning smoking in cars, that was coming on side in Northern Ireland as we were rolling out this particular project. But in Ireland, for example, people talk about, is it the policy to raise the age of which we sell tobacco products to people? Would that help to raise it to 21? And that's something that's coming on side. Another is to have a register of people who may be, who are selling products. And should we actually have less people selling cigarettes? And some of the ideas that were captured in that data was actually saying that actually during COVID-19, for example, when restaurants and off licenses and every other industry shut down, you could still buy cigarettes. You know, restaurants shut at 8 o'clock in the evening, but you could still buy cigarettes. There was no time in when things would be ended there. So it has given us lots of data to be able to move towards how we feed this into policymakers and say, what more needs to be done? And we see that through how we connect up through maternity care services back into community care services and actually supporting people within the homes. So that would be one of the areas of where we're moving forward. Another example, just within the time that we have from our practice that I'll share with you, is around homelessness. And I suppose the smoke-free homes actually highlighted to me the challenges there, because the challenge around how we support people to reduce smoking in the home, and then what we do for people who actually are families where they're actually living in homelessness circumstances. So for that, the design thinking, what we did there was, it was another project. It was, again, to hear the experiences, and where this project emerged from for me was actually my teaching. And the students that I engage with in the classroom were student public health nurses, and actually hearing that they were engaging with families in hotel rooms and that going to family hubs and all the challenges, and public health nurses taking phone calls from people who had no home, and this was all pre-COVID and pre the circumstances we are working with at the moment. So to really to highlight from that idea, actually, well, what's going on there, and to really engage with mothers, parents, to actually identify what we need to do. So UCD seed funding provided an opportunity to be able to hold a workshop to engage with parents, multidisciplinary stakeholders, to get the first-hand experiences of what it was like for people who are engaging with services from the emergency homelessness accommodation and what the impact is on their health. And we engage with policymakers and all NGOs and everybody all the stakeholders and actors that are working in that space, and actually engage with parents as well. And what we wanted to do was to explore with them potential solutions that were there, and to come up with ways that maybe to offer their perspective of what could happen, and to prototype that further in a report that we have produced. So what happened? Well, on the day and in advance, we held a workshop, and that was held in the Mansion House. And from that, we used design thinking. So very many ways to capture that data through roundtable discussions, through the people who were all attending, through the different perspectives and the different lens, and allowing voices to actually contribute. Parents were invited, and there were conversations held with them in advance, but to be able to support them if they were unable to attend, we used other ways to bring empathy into the room, through storytelling, through photographs, and actually using a photo voice presentation that had actually been undertaken by another researcher, Dr. Maria Quinlan, and to have those photographs placed around the Mansion House as well. Because as it turned out on that afternoon, the parents who actually were going to come didn't attend because they were too frightened, and we acknowledge that and we understand that, and I met with some of them subsequently afterwards. But the ideas that emerged from that particular meeting were the challenges around relationships, emotional well-being, environment, physical and mental health promotion, and service coordination, and what we could do around that. And when people were asked during that workshop, what were the words that actually come up that were really connecting with them through the empathy part, that they had heard the stories around the narratives that were connecting with from the experiences from public health nurses that were sharing, and from what they heard from the Ombudsman for Children, for example, these are the words that emerge from people that are just captured to kind of identify where that empathy phase was very powerful in understanding and what messages were being communicated that way. So the ideation and the prototyping led to, for us to understand ways to consider what more needs to be done for parents, and actually how we can actually support them. And we developed up then a policy brief then to look at how we address health and challenges for children and families in that particular way. Some of the areas was the complete lack of data that is on them, the lack of joined up thinking, but most and in particular was the absence of their voice in any decision making that is taken as how they navigate different systems and what is happening through them. So I think I'm at the point of where I am here. So I've stopped screen sharing here and hand back to you, Thilo.
Okay, thank you, Kate. And we continue basically with the topic of homelessness. So we are working very closely with one of the PPI Ignite partners, is the Dublin Simon community. And we initiated sort of conversations with Dublin Simon actually very early on in the process of the larger PPI Ignite grant, and made them sort of our local partner. But we also then wanted to, in the beginning, really learn of, what matters to clients the most, those who have become homeless. And so what are the concerns and issues? And so we attended a speak out, a so-called speak out, which is handing over basically the control of the agenda to the clients of Dublin Simon Services. And they invited us in to talk about sort of research areas where they felt like we needed that, or they felt like there needed to be more attention. And one of the examples was was summarized as, or entitled, "A Home Away from Home." And that generated a number of smaller projects. And I'm going to talk a little bit about, mostly talk about one project here that resulted from that initial consultation event. And so we wanted to understand sort of some of these challenges in greater depth, and wanted to address at least a number of these interlinked challenges as part of a design thinking cycle. And so we formed a design team which involved 3 homeless clients of Dublin Simon, 1 key worker, and Kate and myself. And we engaged in 6 workshops, and these followed pretty much sort of design cycle. And at each stage, we learned from each other a lot. Certain things took longer than anticipated, or the language that we used initially, or the pre-understandings that we had, were not necessarily clear, and we had to go back to the drawing board and really sort of work through the process so that we were all on the same page. We worked through the cycle and defined, we understood some of the key challenges by really working closely with the 3 homeless clients, who really explained to us what it would be like, to enter homelessness, what it would be like to spend the first few days in homeless accommodation, what would it be like to be dependent on some of the treatments that they would receive, and so on. So we spent quite a bit of time talking to them about what is it like, and they were very open, and honest about their experiences, and also what they've observed and witnessed. And this phase can be done in different ways. And in a different project, we had a much more extensive, actually, data gathering exercise, including observations and interviews and so on. But anyway, in this project, we listened and defined then the challenge, and the challenge was very much focused on how you navigate the complexity of the support system. Or even the absence of the support system, but how do you navigate that system? And then we brainstormed or ideated a number of solutions, and we tested, so sort of cognitively tested those solutions through what's called personas. Those personas are how do you describe that? Those are individual lenses or perspectives that we've created based on the pre-understandings of who might be homeless, who might be these people who have a stake in this, through a female lens, a male lens, through an older person, a younger person. So we asked them to create a couple of those personas, and also one for the key worker and care worker. And so we looked at whatever they suggested as a potential solution from all these different angles, and then we built the prototype. And the prototype, a prototype in design thinking could be a service, it could be a tool, a design, it could be an object, but here it was a form of intervention. And so what they've come up with was to develop a prototype for a peer navigator. And peer navigation has been used in a number of other healthcare contexts a lot. In rehabilitation, for instance, it has been used in spinal injuries, in stroke, and other areas where people get assistance through someone who has also experienced the same situation, but helps them to navigate sort of that system. Rehabilitation, it would be so after they get discharged from hospital, how to navigate some of the complexities of lives with a disability. So here the peer navigator is about when you enter homelessness, how do you navigate the system? What are the things that you need to know? Where do you need assistance? Where do you need additional support? And these are just two photos to illustrate what that looked like. So we spent a lot of time brainstorming, and you see there on the left-hand side sort of some of these personas, the lenses that we looked through. And then the prototype on the right, which is really very hands-on, building some of these things, so we get to the stage where we have a good idea of who this person, who this peer navigator would look like, what would look like. And we also have a good idea how it could be implemented as part of the Dublin Assignment Services. So now we're at the stage of looking at identifying people who are potentially willing to act as peer navigators in the system, and then to evaluate the system or the approach. So the benefits that from the process so far that we can say, or that were articulated as part of our discussions and also observations, that apply for this project, but potentially also to some of the others, is that for the clients, it is applying existing skills that sometimes are not very visible because there's this label of homelessness or looking for basic survival, basic existing, but there are existing skills in many ways, and trying to make use of them and bringing them out to the open. So creating sort of creative confidence in the process as well, trusting yourself and having something to contribute and trusting your skills, as well as discovering from others and working with others, with the team, new transferable skills, and developing new insights as part of the team experience. And many articulate actually also sort of a sense of wanting to give back, and see a purpose in doing this, for people who come after them. For organizations, it's to look at individuals not only as clients and service users, but really harnessing sort of the creative potential that they bring to an organization, to have interventions that are not clinical in nature, but looking at something that's life-affirming and positive, to bring them into program design, for themselves, for the organization themselves, for Dublin Assignment, to learn, what users really want and how can we improve the service and processes, and a mutual communication, improvement in mutual communication and understanding. So in conclusion, we just want to have a bit of time, 5 minutes for this question and answers, but just to address maybe some of the challenges in co-design. So first of all, one of the challenges is who sits around the table, who's represented in the design team. Kate mentioned the so-called seldom heard groups. So oftentimes, I think even in co-design, it happens, that you engage with people who are most articulate, perhaps have the closest education to yourself, similar socioeconomic background. So So there's a call, to broaden the representation of design team to make it as inclusive as possible. The second challenge is the mutual benefits and values, understanding, is there something in it really for both, or for all parties, for all stakeholders in the process? What are the values? What do they value? And is this process, consistent with their values? How do you build the relationships, and how do you find ways actually to ensure that relationships are maintained appropriately, but also bounded potentially, and that the roles are clear in the design team, that people are not just there to tell their life stories, but to use or to bring in the experience as a complementary element to the skills that other people have on the research team or design team. And then communication language, adapting sort of the language so that it becomes not too academic, but really ensuring that understanding is there. Maintaining the focus on the task at hand is important. And then oftentimes, people ask, where's that recipe book, the standard for how to do it. So I think my answer is not rocket science, but it is to tailor it to the circumstance, to be in empathy mode, to listen and to see what works in the context, in the situation. So manualization and standardization to the extreme is not going to work here. Yeah, so there are several lessons from the field, from Stoli. So why co-design might be appropriate. So status quo of healthcare system is constant change, and we talked about that initially, about that systemic development. Health systems research cannot be done in a laboratory because of the complex nature. There are some practicalities around co-design contradiction, that grant application reviewers want a clearly laid out, often intervention plan, but when you co-design, you have to develop as part of the process and not just presuppose or assume that you have all the answers right from the start. Patient and family care, caregiver engagement, critical in healthcare, but it's hard to do well. We talked a little bit about that. And similarly, it's applicable to healthcare innovation, system transformation. And so Kate already talked about sort of why it is important, to have more rapid responses, so rather than waiting 17 years as the often cited Ballas paper from 2000, to get innovation into practice. So I think with that, we get to the point to just thanking you and happy to answer any questions.